Welcome everyone to today's SIEPR Associates meeting. I'm Mark Duggan, the director of SIEPR, the Stanford Institute for Economic Policy Research, and it's really an honor to have Dr. Vivian Lee with us this afternoon. But before we get started and I turn things over to Vivian, I just wanted to take a moment to reflect on the passing this past weekend of the honorary chair of SIEPR's advisory board, former Secretary of State and Treasury Secretary, Labor Secretary, and OMB Director, George Shultz. He was an inspiration to all of us at SIEPR and has supported us in countless ways over the years. Quite a few of us at SIEPR had the honor and pleasure of connecting with him about 10 days ago when we celebrated 6 weeks late his 100th birthday and officially informed him about the creation of an endowed Shultz Faculty Fellow position at SIEPR. He was a brilliant, kind, and principled man who did so much to make Stanford and the world a much better place. It is really a gigantic understatement to say that he will be missed, and all of us at SIEPR send our deepest condolences to his family. We'll particularly miss him during our upcoming SIEPR Economic Summit, which kicks off in just 3 weeks. I'm sure the issues that we'll be covering during that week-long event would be of great interest to him, and I'm very much looking forward to seeing many of you online for the terrific sessions that we have lined up. I also want to highlight briefly some of the research that our scholars have been working on lately. Susan Athey, one of our senior fellows, has worked with several colleagues on a sweeping analysis of COVID vaccine production that offers insights into how governments could better prepare for future pandemics. And just in time for the upcoming tax season, one of our faculty fellows, Jacob Golden, has new research looking at how to get more people to take advantage of the earned income tax credit. And I recently had an op-ed published in The Hill that discusses reforms to how the US Department of Veterans Affairs awards benefits to veterans with service-related disabilities. And I'm expanding on those ideas in a SIEPR policy brief that will be released later this month. These are just a few examples of the timely research that we're producing at SIEPR, and I'm incredibly grateful for all of the support that so many of you have shown to help make this work possible. And today, I'm absolutely thrilled to have Dr. Vivian Lee with us. She's going to be talking about rethinking the business model of healthcare, and she is the perfect person to lead this discussion. Vivian is the president of health platforms at Verily Life Sciences, which develops tools and devices to collect and organize health data to help prevent and manage diseases. Vivian is also a senior lecturer at Harvard Medical School and is the author of The Long Fix, Solving America's Healthcare Crisis with Strategies That Work for Everyone. Before joining Verily, Vivian was the dean of the medical school at the University of Utah and the CEO of its health system. She also served as the inaugural chief scientific officer of New York University's Langone Medical Center. Vivian was elected to the National Academy of Medicine with over 200 peer-reviewed publications. She serves on the Defense Health Board of the Department of Defense, the board of directors of the Commonwealth Fund, and is also a director on the board of Zions Bank Corporation. I could go on and on and on with Vivian's many accomplishments and positions. But I want us to hear from her on the substance. So I know that we're going to hear a lot of great insights today, and I'm sure that many of you will have questions for Vivian. So please send them in to us through the link on your screens, and we will do our absolute best to get to as many of them as we can. So with that, let me welcome Dr. Vivian Lee to SIEPR, and thank you all so much again for joining us. Take it away, Dr. Lee.
Thank you very much, Mark. It's really wonderful to be here. Thank you for that very kind introduction. And I feel really honored to be a speaker for you. I'm going to move to some slides. So let me just go ahead and share my screen. You can let me know if you can see these slides. Okay, I know I'm not in present mode, but this way I can still see you all, which is helpful to me. Wonderful. So, let me just get myself organized here. So as Mark alluded to, I am on this virtual book tour, talking a little bit about this new book that came out last year called The Long Fix. And it is a book that is really intended primarily for the lay public and for those who are interested in learning more about our healthcare system, and is intended also to be an optimistic book about healthcare, which some have told me is sort of an oxymoron. But actually, I don't believe so. I think from talking with people from across the country, learning a lot about success stories and really positive developments, I think that we can weave together a vision for how healthcare can actually be much more successful in this country than it is. But fundamentally, what makes healthcare as a challenge so particularly interesting, I think, is this fundamental paradox, which is that we in the US, as many of you know, spend so much money on healthcare. We spend 2.5, 3 times as much per capita on healthcare as any other high-income nation. And yet, by almost every measure of performance, we are significantly, not just marginally, but pretty significantly underperforming. And here, for example, if we look at life expectancy, we can say that the average baby born today in the US was projected to live 4, 5, or even 6 years less than the average baby born in, say, Italy or in Japan or Switzerland or Israel. And how can that be that we are spending so much money and yet generating so little in return? Well, of course, there are many factors. One of the most important, I think, is the fact that the dollars that we're spending are not evenly distributed across our society. And while we saw the Affordable Care Act significantly improve the rate of insurance in this country, COVID has really, and other events have actually pushed us back a little bit. So the Commonwealth Fund, on which I'm actually on a member of that board, just in full disclosure, put out a report for the first half of 2020. They did a survey and found that over 40%, around 43% of working adults reported being underinsured or unstably insured. So increasingly, we're seeing that our dependence on employment for healthcare access is really proving to be quite challenging, particularly in light of COVID. I share the latest update, and of course, I'm pleased at least the trend is going down now. But nevertheless, the impact of COVID on our healthcare system and on our public healthcare system has just revealed so many more flaws and so much a greater urgency for the need to tackle these problems. Now, one of the silver linings I think about the pandemic has been the really remarkable behavior of our healthcare workers, the frontline providers, our scientists, our immunologists and epidemiologists. I just heard recently that there's a record number of students, for example, applying to medical school this year. And so for those of you who are working on the front line, if any of you are frontline clinicians, I just want to thank you for all that you've done, and to say that we really are full of admiration and very grateful. What's not a silver lining, of course, is the economic impact of the COVID pandemic. And I'm sure, especially in this audience, have been tracking very closely the impact of COVID on the economy and on the rising deficit. And there are significant, in turn, implications for how we think about the future of healthcare, because healthcare is such a significant part of our spending in this country. So here are some data from the Congressional Budget Office that was released in the fall. Prior to COVID, the estimates were that the Medicare Trust Fund Part A, which is the part that pays for hospital-based care, was projected to become insolvent by 2026 or 2027. With COVID and its implications, that's moved up to 2024 now. So among all of the issues that this administration is going to have to deal with, this is yet another significant challenge. And I was speaking with a colleague of mine, Liz Fowler, who is now at the Commonwealth Fund, who has been at the front lines of legislation in healthcare for many years. And she just simply said, look, when you're talking about budget cuts with Congress, their approach is really to take a meat axe approach rather than a scalpel. It's going to be across the board cuts if we aren't careful. And of course, that's the last thing that we need right now. So it is ever more imperative that better models of healthcare that can generate more value for the dollars that we're spending be implemented. And the good news is that across most of my colleagues, the people that I have interviewed, for example, for this book, when I've asked them, what's the one thing you would change in the US healthcare system, the vast majority answer, it is the payment model, that we need to move from a fee-for-service model of care, paying for things to be done to us, instead to a model where we're paying for health and paying for better outcomes. And this is actually a bipartisan view. It may be some of the words that people use might be a little bit different, but the overall idea of needing to move away from fee-for-service to a value-based healthcare system is shared nationally. The challenge is, of course, it's so much more difficult to move from a fee-for-service model to a value-based model of care than it is to make a slide suggesting that we do this. And as somebody has lived in this world, has served as a CEO of a healthcare system, as a chief scientific officer of another healthcare system, I can really say that it is a significant challenge when every element of infrastructure, of compensation, of incentive, all of the data and reporting has been really focused on driving a fee-for-service business, and to move that into one that in some cases is almost 180 degrees in 180 degrees opposite direction in terms of what it's trying to motivate. For example, more hospitalizations on fee-for-service versus fewer hospitalizations in value-based care. The challenges of the transformation are huge. So I wanted to tell a story. I wanted to start with an example of just where that significant pivot has been, in my view, very successful. And I think it's nice to start with a positive and kind of optimistic narrative. And so I'm just going to read a very short segment from the beginning of this book that is from chapter 2, called An Apple a Day Keeps the Patient Away. And here I'm actually I talked to Chris Chen, who is the CEO of Chen Med, which is a large Medicare Advantage physician group. And he's actually talking about his father. And it starts with a quote about how people used to talk about his dad. So it starts with a quote: "Go see that crazy Chinese doctor who takes care of all the poor Cubans." Chris Chen grins as he tells me how people used to rave about his father's clinic in Miami. His father had started as a typical primary care doctor in private practice. He was paid fee for service, which meant the more patients he saw, the more he earned. Then in South Florida in the early 1990s, a few insurance companies started experimenting with new ways to pay doctors. Instead of fee for service, they gave them a fixed amount per patient each year. If a patient needed expensive imaging, costly drugs, or long hospitalizations that added up to more than that amount, it was the doctor's problem. Chris's dad, the doctor, and mom, the office manager, experimented in this new model. They welcomed referrals, but other doctors sent them only their frailest and poorest patients, the ones they knew would be grossly unprofitable under this new way of paying. That's how Chris's parents began with 250 of the sickest people in Miami, people who would have been almost impossible to keep well at any facility at any price. It looked as if the Chens had signed up for a financial suicide mission. Because resources were scarce and their patients' needs were many, the Chens decided to focus on primary care and prevention. Their fragile elderly patients had to be seen frequently by doctors. Once they got sick, it would be too late. So they set up monthly visits, even if there was nothing wrong. Getting to the clinic would be tough for many of them, so the Chens provided free door-to-door transportation. They worked out that diverting the cost of just one ambulance ride in hospital stay could pay for a year of shuttle service. They opened a pharmacy in the clinic so their patients could conveniently, cheaply, and reliably fill prescriptions. And since their patients often had complex needs, physicians in the clinics conferred several times a week about how best to treat those who weren't doing well. Somehow, that crazy Chinese doctor and his wife not only provided outstanding care for their patients, including many who often didn't have enough to cover copays or deductibles, but they also managed to make them healthier. They reduced hospitalizations, and even more amazingly, they broke even financially. Out of desperation, the Chens invented a better way to do healthcare. So that model of paying physicians a fixed amount of money for a population for the year, and then giving them the autonomy to decide how to spend those dollars, really ultimately grew into the Medicare Advantage program, which, as you may know, is one of the fastest growing programs. Now, Medicare Advantage makes up about 40% of the Medicare population. And interestingly, during the COVID pandemic, we've seen that not only does this capitated or global payment model, this paying for value model of healthcare, not only does it lead to better health outcomes, and I think a greater sense of autonomy and satisfaction on the part of the physicians and clinicians, but it also creates a more robust healthcare system. So back in April, I think many of you will remember that as the pandemic was really, its impact was really being felt across health systems. Most clinics and elective procedures, for example, were being postponed. And I think in April alone, over 1.4 million healthcare workers, physicians, and nurses were furloughed. And at that time, actually, I reached out to some of these groups like ChenMed and Iora Health and Presbyterian in New Mexico, for example, and others, as well as the folks in the military health system, which are also under a global payment model, to see how they were doing. And in fact, it turns out that because these Medicare Advantage programs pay the clinicians on a monthly basis, instead of relying on a fee-for-service model, they had their guaranteed income during the COVID pandemic and were able to actually invest those dollars in providing care for the seniors that they were responsible for, including providing more home-based care, providing more delivery services, for example, for medication refills, as well as even converting some of their relatively empty clinics into urgent care centers at a time when most seniors were very afraid of going to, say, an emergency department. And Christian actually called this a subscription kind of based model and put forward that, instead of worrying about how you're going to re-up your services as soon as the pandemic stopped, medical groups that are on more of this subscription funded model were able to step up and make sure that they could actually keep their patients healthier. And there are already some initial data coming out of at least the ChenMed group showing that they had lower mortality due to COVID as a result of some of this work. So of course, we'll look forward to more data on that. So I wanted to start with that story and just to say that really is what this book is all about. It's about thinking about what does a better model of healthcare look like for patients and their families and communities. What does it look like for clinicians? And what I just described is from the perspective of outpatient clinics, ambulatory care. Of course, there's significant implications for hospital-based care. And so I talk quite a lot about that. And then how does it look for other industries, such as the pharmaceutical industry? What if we actually paid for medications based on their cost effectiveness? How do we think about implications for big data? And then a big focus on some, I think, untapped or underutilized levers in here, which include employers, which I'll talk about at the end today, as well as focusing on an integrated payer provider system within the government, the military health system, and the VA. And then, of course, bringing it together with some policy recommendations. So for the remainder of the time today, having talked a little bit about this basic premise of moving from fee-for-service to value-based care, I wanted to focus actually on this theme of co-production, and in particular, co-production as a means of engaging the three key constituents in this fundamentally challenging behavior change problem of healthcare reform. And those three are providers and clinicians, patients, and then payers, specifically focusing on employers. So let me start with this path from caring to co-producing, and maybe introduce this idea of what I mean by co-production, and an idea that I've borrowed from others as I'll talk about. So in the beginning, and I would say for most health systems, there is a journey that we are all undertaking, which is one where historically, traditionally in healthcare, the clinician, and I would actually argue the physician, is pretty much positioned as the center of the universe. And shifting that mindset to the patient and their families as the center of the universe has actually taken quite a long time and taken quite a lot of adjustment. But that's actually a necessary first step to moving towards this idea of co-production. So I'll just spend one moment saying a little bit about that before I focus on what I actually would like to talk about with co-production. When I first joined the University of Utah as the senior vice president and the CEO of the health system there, I inherited a system that had been really struggling under my predecessor with poor patient satisfaction scores. And he had really taken it upon himself to move the organization. And he launched an effort called the Exceptional Patient Experience, arguing that, a health system can't be great if the patients or your customers don't think you're great. And brought along the organization from starting with measuring, getting patient feedback. This was back in around 2010, 2011 when he started this, or maybe even a couple of years before that, providing that data back to providers so that they could have feedback. This is universal now, but it was quite unusual in its time. And then making those data about performance increasingly transparent. And over time, what we discovered was that by having that constant patient feedback, at least hearing the patient voice almost daily, that feedback, it really shifted the mindset of the organization and the physician practice to one that became much, much more patient-centered. We still have a long ways to go because, as Justin Masterson, who is a parent of a patient, said, articulate, I think, very clearly, I think most of us in healthcare forget that really the vast majority of what determines the health of an individual happens outside the four walls of the clinics and the hospital. And really, for the most part, it's individual behaviors and the behaviors of their family and the community in which they are living that really most determines their overall health. And so if we start thinking about health that way, then we can start to imagine that it's really a co-production. It's really a joint effort between healthcare delivery systems and patients. And this idea actually, I think, came from a paper that Maren Batalden and Paul Batalden wrote a few years back, who brought to my attention this article by Victor Fuchs from 1968. And I don't know if he's on the call or not. I'm really interested in his thoughts and feedback about how I'm representing this work. But this fundamental idea that as the US economy was moving from a manufacturing economy to a service economy, the relationship between the producers of those goods or services and the customer was going to evolve. And that evolution, I think, is something that we're going through in healthcare now. So in a manufacturing environment, you have the manufacturers, they produce the good, the car, the pair of jeans, whatever it is, and then they sell it to the customer who essentially uses it pretty much independently of that manufacturer. And whereas in a service economy or in a service model, there really is much more of a partnership, of a working together between the producer of that service and the consumer. And some of the examples that the Bataldens use in their paper include education, include fire safety, include waste management, where we don't just rely on, for example, the schools to provide education for our children. We participate, we help them with homework, or we join the PTA, for example, or we also have smoke alarms and fire extinguishers in our house as part of that co-production for fire safety. And in my mind, we have often in healthcare been thinking much more about a manufacturing model, that we produce health and we hand it over to our patients. That's probably true in the intensive care unit and in the operating room, where we are predominantly responsible for the delivery of health. But for really most of healthcare and most of what matters in health, especially around prevention, it's really a co-production. And the reason why I can give you a few examples of co-producing health. Some of these examples include the centering pregnancy model, which brings together a number of women in their prenatal journey together. It's been led by actually some nurse midwives across the country, and has been shown by bringing these women together with a healthcare provider, but often peer-to-peer working together, that there are significantly improved rates of, for example, breastfeeding and healthier lifestyles. And there are a number of examples here. One of the reasons why I particularly focus on this narrative is because I think that we've seen a real need to recognize this co-production during COVID-19. So the vast majority of patients who have been hospitalized or suffer from COVID have underlying chronic conditions like diabetes, like respiratory, pulmonary diseases, cardiovascular diseases, and yet they have not been able to access our healthcare facilities. And so ever more important that we think about their health as something that is co-produced. And in this vein, this is where digital technologies, telehealth to begin with, and other digital technologies, I think have a really vital role to play in enabling and facilitating that co-production. So we've seen during COVID, finally telehealth has taken off. Teleradiology, my own field, has been in practice for 25, 30 years, but because of regulatory and payment issues, it really hasn't become the norm for most of healthcare until very recently. That's clearly beneficial, especially if your primary interaction can be done just verbally. But we also know that we need other measures of, of a patient's health beyond just being able to talk to them. The physical exam includes more than talking. And that's where many of these digital health solutions have really taken off, especially during COVID, whether they are focused on people with diabetes or in mental health or in a number of different conditions. And I particularly can call out one of the diabetes products that I know very well because it's one that I'm responsible for, that is called Onduo. But I would say that the results what I'm going to describe to you are very similar to its competitors like Livongo and Omada, for example. But as an example of how Onduo, as a digital health solution for people with diabetes, can co-produce, it's really about understanding. Maybe I can just explain how the product works, and then you can get a sense of how that co-production can really be affected. So it starts with a sensor, a continuous glucose monitor, and there are a number of these on the market. And these are probably the size of a key fob, and you put them on your arm or on your abdomen, and they basically estimate a person's blood sugar 24/7, instead of requiring them to have to prick their finger and do the drop of blood on a glucometer. The continuous glucose monitor has a small Bluetooth chip in it, which transmits the signal to an individual's phone or their app. And so you can see in the middle image here, the tracing, which is of that individual's blood sugar. And so what we know there immediately is we actually have the personalized data. Everyone's blood sugar actually responds and has very unique signatures. And with patients taking pictures of their meals and snacks, this is really the first time people are able to make a visual association between what they're eating and how it's affecting their blood sugar, or how they're exercising or sleeping, for that matter. And of course, in this particular case, you may not need artificial intelligence to tell you that might not have been the best breakfast choice. But there are AI algorithms that, of course, can make observations about individuals' specific patterns. So whether it's, Mark maybe do better with soy milk in his coffee, I maybe do better with skim milk, for example. Those are actually helpful insights. And then the telehealth, the ability to text, the ability to video conference with a care provider, of course, is absolutely essential. So across all of these digital products, whether it's Onduo or Livongo, Omada, all of them are showing significant improvements in blood sugar control among people who use these technologies. And so far, they appear to be sustained improvements. And I use these as examples of co-production, where we are able to provide the clinical guidance using a little bit of AI actually on top, and meet the needs of patients where and when they need them. And this model is, there are many models that are out there. Here's another example. Ariana Huffington has a company called Thrive that is now partnering with Walmart to present a mental resilience app that's very much about social connections across individuals and micro steps in behavior change, for example, around weight loss. A third product that I think is also very interesting that I've just become introduced to is around smoking cessation, one of the biggest public health challenges with really the highest returns on investment if we could really succeed here. Very similar model again. Here they have a carbon monoxide breath sensor. So that's the equivalent of the continuous glucose monitor. So individuals blow into this and they have a measurement of how much carbon monoxide is in their blood. And that's a significant point of engagement based on the data that these folks have reported. People they don't want to have that much carbon monoxide. They don't like the red signal here. And then what it does is really encourages people to start to reduce their tobacco consumption and then actually attempt 24-hour quits. And so all of these are examples of digital solutions really working between the provider systems and the patients in order to engage people in the co-production of their health. And when we remember that as much as we focus on clinical care as a determinant of health, health behaviors and other social and economic factors are significantly more important. So for those of you who have not had much of a chance to interact in the digital health space, I right now am encouraging everyone to try it. I think we're in the infancy of digital health. There's still a lot of evidence that's going to need to be generated. There's a lot that needs to be worked out around data privacy and security, as well as around the payment models here. But it's going to be a very interesting next few years as many of these issues get worked out. And I think the more of us who get in early and understand and can actually contribute to those developments in a positive way, I think the better. Hand in hand with this idea of individuals as co-producers of health, there's a significant role for employers as payers. And I think this audience knows well that in this country, we have this unique system where the health care of over half of all Americans is provided by their employers. And what we've seen is that the increase in healthcare costs for employers and the corresponding increase for the employees themselves is just dramatically increased over the last couple of decades. Actually, dramatically increased from World War II when this whole process began. And I talk about this a lot in the book. I think in the interest of time, I probably won't go into a lot of the data because I think many of you are probably really familiar with it. But we do know now that, for example, the increasing shift of the financial burden to the employees has continued to rise. And now employees bear on average about 30% of the bear about 30% of the cost of care through their co-payments, deductibles, and co-insurance. And that the piece that is borne by the employers is coming out of fundamentally our collective paychecks, that over the last 50 to 60 years, wages on average have essentially stayed flat while healthcare costs have increased. And even more worrying, the percentage of the dollars that our employers are able to put into our retirement funds is also getting attenuated as a result of rising healthcare costs. So one of the lessons that I share when I'm talking with the lay public about healthcare is, if you think that just because you're insured that you're not paying for your healthcare, think again, because you're paying for it at least 3 times over. You're paying for it, of course, in your out-of-pocket expenses, which have continued to increase and now is about 30% of your overall healthcare. You're paying for it out of your lost wages, which may be invisible to you, but it's definitely can be seen by our economist friends like you all. And then, of course, you're paying for it out of your taxes to support Medicare, Medicaid, and other government programs. So we are definitely responsible for our healthcare. And we know that that this is a significant part of the budgets of most employers. And this shift recently to high deductible health plans has really, took off in the last decade. And most of the data suggests that while there's an initial savings in the first year, employees do reduce their spend if they have a higher deductible plan. Of course, there's also some selection bias and everything in the research around this area. Nonetheless, I think overall, it does not reduce subsequent increases, and most the studies that I've seen suggest that people they're indiscriminate in their reduction in the use of healthcare. So when they have a high deductible health plan, they may not realize that preventative care is still covered, and so they tend to forego that preventative care as well, which is a concern. So what can we do about it? Well, I think there's some really interesting model. Of course, we could shift completely away from employer-sponsored healthcare altogether. I'm sure many of you in this room will have some views about that. With employer-sponsored healthcare, I think there are a number of steps that employers can take. And uh, there's a story that I tell in the book, which I will briefly talk about now, which is about how do we engage employers in um, being in their role as drivers of change, helping to get more value, helping to get better health outcomes for their employees, and to lower the costs of care. And this is a story that I tell. I have a whole chapter dedicated to this issue of employers. And it's a story about Bob Mecklenburg, who was the chair of medicine at Virginia Mason Medical Center in Seattle. And I'll just read you just actually a very short segment so that we can have time for questions. In December 2004, Bob Mecklenburg received a visit that pretty much ruined his Christmas break. Mecklenburg was chief of medicine at Virginia Mason Medical Center. His hospital was paid to provide health care to employees of 4 of Seattle's biggest companies and employers: Costco, Starbucks, Nordstrom, and King County. In his office that day was the medical director of Aetna, the third-party administrator for each of the 4 self-insured employers. He told Mecklenburg that the care provided by his hospital was too expensive, and that unless something changed, they would dump Virginia Mason. Mecklenburg, who is responsible for hundreds of millions of dollars in his department's annual budget, most of which was clinical revenue from caring for patients, had a startling realization. I had never come face to face with people who paid my salary. I thought Virginia Mason paid, but it was really these employers. He wanted to understand the problem better, so he asked the 4 HR heads what was driving their climbing healthcare cost and lost employee productivity. Back pain and headaches seemed common, they said, but beyond that, they weren't sure. And I go on to tell the story about how he got access to all their claims data. He called it his Christmas kitchen table research project, broke down all the component costs for them, tried to look at why Virginia Mason's cost of care were so high for those individuals, and really came down to the conclusion that he sort of had an epiphany, which was that really this was like a supply chain issue for the employers, that the health of their employees was the equivalent of, let's say, somebody having poor health, or a healthcare system delivering poor healthcare was the equivalent of Intel receiving a poor quality chip, for example, from one of their chip manufacturers. That if employees couldn't work, Nordstrom couldn't sell clothes, and Costco couldn't restock their shelves. And so in working together with those 4 HR executives from these companies, he actually came up with these performance specs that Virginia Mason would have to meet in order to keep their business. Number 1, give us what works and skip the rest. So let's only do practice only evidence-based medicine. 100% customer satisfaction. You can imagine Nordstrom was a big fan of that. Same day care. You wouldn't expect somebody coming into Starbucks to wait a couple of weeks for their skinny latte. Rapid return to function. We actually in healthcare have never been challenged by that. How quickly are we returning employees back to the workforce in a healthy way? And then number 5, predictable and consistent prices for buyer and seller. So in all of these, actually, as I tell the story about how Mecklenburg managed to work with his team to make those things happen, of course, it improved the performance of Virginia Mason altogether. And it's what led them to become a center of excellence for, say, Walmart and Lowe's and a number of other national employers. And I think it's an example, one of many examples of how employers working together can apply their own business expertise. They actually, several of them help bring in some of the lean practices into Virginia Mason in order to get better outcomes for their own employees. And now, as we're moving into this post-COVID period, I think they're also identifying digital health solutions as a potential powerful tool for their employees in order to achieve that better health. So we're starting to see some of that co-production span across payers, providers, and patients. So those were a few of the remarks that I wanted to share with you, and I'm happy to turn it over back to Mark for any questions. So thank you again.
Thank you so much, Vivian. That was really interesting. And I don't know if you want to stop sharing your screen, although we can. Okay, great. Yeah, great to thank you again for sharing those insights with us. There are so many things that I would like to ask you about, and we've got lots of great questions from our audience. So I'm going to sort of alternate. I'm going to ask a question and pull one from the audience and so forth. And so just to start off, I'm curious, would you say that your book is more about tackling, like trying to lower costs? Or would you say it's more about trying to improve quality? Or like, you can't say both equal. So as a health economist, I'm
Well,
very frustrated by the US healthcare system because I think we are operating inside what economists refer to as the production possibility frontier, which is to say we're either spending more than we need to for the increment to health or not getting as much increment to health as we could for the amount that we're spending. So in any case, I'm just curious, what side of the equation do you feel more energized about in the book?
oh, that's easy. It has to be improving quality. It has to be improving health and improving health outcomes. Um, Interestingly, where we are on the curve, better health outcomes can lead to lower costs. So often we sort of associate, there's of course there's the cause and the effect, but better health outcomes, reduced complications, reduced readmissions, obviously more preventive care, provides the biggest return on investment. Better look at what we would have, look at how we would be spending across the economy now if we had a strong public health infrastructure and had been able to prevent millions of cases of COVID today. So absolutely a focus on quality, better health outcomes. And a significant, I will say, one piece of that quality, as we talk about it in kind of general terms, there are many, many dimensions to quality. But I have to start with access. You really can't have quality health care if you don't have access to health care. And so I just want to premise that to say, fundamentally, you have to have an assumption that to get to quality, everybody actually needs to have access to care first.
Great. Thank you for that. Now I'm going to pull a question from the audience, which is, I know, I talk with many students here at Stanford who are considering medical school. And one issue that they weigh and think about going to medical school is how much debt they will have to incur. And so, and part of the reason that economically it makes sense is that we pay physicians much more in this country than our industrialized country counterparts. And so this question, I'm just giving the background for this question. Do you see the cost of medical school standing in the way of moving to a paying for health model? Will this transition necessitate a shift toward healthcare jobs being less lucrative?
The way I think about it is that in a value-based system, we value primary care. We actually even value public health people. We value primary care significantly more than we do now. And I actually saw, we already are seeing, we saw some of it play out even more. Let's see, there was a time when maybe around 2015 or so, when Secretary Burwell, Sylvia Matthews Burwell, who was the Secretary of HHS, essentially declared that CMS, that Medicare would achieve pretty ambitious targets around moving to an alternative payment model. And I was at the University of Utah at that time. And of course, after she made that statement, a number of the private insurers also followed suit and said, yes, we are also going to go to 75, 80% alternative payment models. And we could see across the country there had already been a buildup since the ACA towards that. And there's a shortage of primary care physicians. And we saw actually a pretty substantial rise in salaries for primary care docs, for us to be able to recruit them and attract them, because there's a shortage across the country. So I guess that's kind of where that question has sort of two parts to it. The first part is who should pay for medical education and what should that model look like? Because that question assumes that it should continue to be funded the way it is now. So And the average student, I think, emerges from medical school with $150,000 in debt just for medical school alone. So, there are many programs around the world where that is not the model, or we do even have models in this country where that debt is forgiven in exchange for service. The military health system is one example. There are rural health programs. There's also, if you go into research, there's some forgiveness programs. So we could actually tweak that model. So that's, one piece of it. But I think the question is more specifically around the market. And there, if the payers reward primary care, if prevention is what makes ChenMed money, ChenMed is going to invest in primary care docs, not necessarily orthopedic surgeons. And I think we started to see some of that shift, but I think we've taken a step back again in the last few years.
Great. Thanks for that. You mentioned a bit, you mentioned quite a lot, the pandemic. And I'm just curious, as you look out at the world and see how things have evolved here in the US, and things have been very different in different countries at different times, with the lead up that, of course, this pandemic, to use the overused word, unprecedented. So it was hard to predict in so many ways, right? But with that caveat, recognizing that there are gonna be missteps and so forth, inevitably, when you're confronted with when people on the front lines and policymakers, so forth, are confronted with something so big and so challenging and so unpredictable. But with that caveat, what grade would you give, let's say, policymakers so far in the U.S. during the pandemic, and where do you, inevitably, you can't be perfect. Hindsight's 20/20. So, if we'd done, but high level, what would you give? How would you grade policymakers, taking into account your considerable healthcare expertise, your knowledge of the policy apparatus, and so forth?
Well, that's a really difficult question. Policymakers, it depends on which policymakers you're talking about and what level. I think that at this, one of the challenges, of course, as you know, is that so much of the policy was actually or so many of the decisions about how to respond to COVID were being made at the state and local levels. So the fact that I think that every local health commissioner and state health department leader was trying to do their best, I hope, but with limited resources, limited data and information, and limited supplies, frankly. And so I think that made for a very, very challenging situation. So rather than grading the policymakers, I guess I would just say that the way in which we try to establish policy or establish a response was probably the most problematic.
Great. Okay. Thank you for that. Now I'm going to pull a question from our audience, and I'm going to include a little add-on near the end. But can you share insights on? So you talk quite a lot about fee-for-service to value-based. So can we achieve this collaborative approach? Where do we start? And I want to know from this, who wins and who loses? Because whenever you make a change, there are winners and losers, right? Like it's nice to engage in happy, like everybody wins, but I'm skeptical. So if we were to fully transform or make a major move in this direction, who stands to gain the most and lose the most?
Yeah, so I actually like to phrase it a little bit differently, and to say who wins, I get that, but who then needs to change the most and redefine the value that they're bringing to the organization or to society or to healthcare. And I use my own field as an example. So I'm a radiologist. I do MRI radiology. And so I would be in the category that I think most people would traditionally consider likely to lose, because the work that I do clinically is high-end specialty care, requires very expensive technology. It's exactly what we're trying to reduce the utilization of in value-based. One of my pet peeves is back MRIs. If anybody's read my book, you'll know I kind of called that out a couple of times. because the vast majority of those imaging studies are probably unnecessary, and they do generate a lot of revenue, though, or they have in the past generated a lot of revenue for hospitals and medical groups. So it's not surprising they're a source of utilization, overutilization. But there, I would say, so using that as an example of people who have been very successful in a fee-for-service model. I think the narrative there is that the model of doing as many MRI scans as you possibly can, and then billing and getting reimbursed for that, has to demonstrate a significant pivot. And in order to be successful in a value-based world, radiologists like me have to demonstrate our value, and we have to reconsider what is it about our imaging tools that are we really improving the health of our patients with the imaging studies that we're performing, or reducing the cost of care. And so some examples for being held accountable in that way that would need to, some examples of how things would have to change to be successful so that we aren't the losers. One example is to think about how we even measure performance of radiologists. So if you look at quality measures, so, for in other fields, you do an operation, is the operation successful, is the person healthier, and so on. In radiology, until recently, the most common measure is, did we provide the report? So did we interpret the imaging study and provide the report within 24 hours? Did we provide a timely report? That's it. Not were we right or were we wrong, but just did we turn it around? And so when I speak with my colleagues in this field, I say, maybe we should be starting to judge ourselves on whether we were accurate in our diagnosis on our imaging study. And I know there was actually years ago, I talked with some folks in the Stanford radiology department, a really fantastic study, which I never followed up on, but was brilliant in my mind, which was using AI to look at all of the images in the library at Stanford. And if the radiologist came across a very difficult, complicated, say, tumor in the liver, could use these AI tools to suggest what that diagnosis could be, could actually tie it with the patient's medical records about what chemotherapy worked or didn't work, could provide a lot of value from that imaging study, other than just a report, because the data could be tied to all kinds of other really important information. If radiologists were being judged on that, on whether they were producing that kind of value and that kind of benefit, I think that the field as a whole would advance much more quickly, make many, many more contributions to better health and better health outcomes. And probably the people who embrace that would succeed. So that's one example.
That's great. Thanks so much. I have another question now. I want to pivot a little bit to a topic that you touched on in your remarks, and certainly in your book as well, mental health. So about a little over 20 years ago, when I was wrapping up graduate school, I embarked on a study of what was driving the really remarkable decline in suicide rates in the US during the late 1980s and throughout the 1990s. And the introduction and diffusion of Prozac had something to do with that, and so forth. But there was a lot, but that's controversial. Even that is controversial. But, and so I remember sort of finishing that paper and getting it published and feeling very good about the world, because the US suicide rate was going down. And my last year of data, I believe, was about 1999 at the time. And in the 20 years plus since, things have gone in a very different direction in the US, at least by this metric. And it's not a perfect metric of mental health, but it's a pretty clean one. By this metric, things have gotten a lot worse in the US. Mental health seems to have gotten, the suicide rate is up almost 40% since I finished that paper. And that is adjusting for age and gender and so forth changes. So it's within groups. I guess I'm curious if you see upside. Like, I think radiology is an awesome example of where value can deliver, moving from fee for service to value can really make a difference. Do we see, does it apply as much to the mental health arena, where as a nation, we're not doing great? I don't know if it's, I mean, maybe healthcare deserves none of the blame for that, and it's external factors. We've heard a lot about external factors, but does it lend itself as well, mental health care improvement, to this model as something like radiology, where your primary expertise is?
There's so much that you've raised in that question, Mark. I'll start by saying I think there was I don't even know where to take this. But we'll start with the fact that since we're talking in this book about one of the core tenets is about the business model, the flawed business model of healthcare. We can start also by pointing there to the separation of mental health from physical health in the business, so that mental health has been a carve out for, I don't know, several decades now. And the ways in which we reimburse for mental health have created real barriers to access to care. It's kind of a rebound. People were really worried about overutilizing mental health services. And so as a result, I think swung way too far on the other direction, so that the access to people who need mental health is really inadequate. I'll just start there. We had an enormous, the impact of opioids on this country, really significant issue. In the company that I work for, Verily, we actually have an initiative in Dayton, Ohio called Project Daybreak, or 115. And 115 is the number of daily deaths due to opioids at the time when we launched. And by the time we actually opened our first facility, this includes a crisis center, an outpatient clinic, and we just opened last week a residential facility for substance use disorders. And we're very much focused. I know it might sound odd that that an alphabet tech company is actually building facilities in Dayton, Ohio, around substance use disorders, but this is something that is very, very important to us. And we've been building the underlying technology to be able to support these individuals throughout their care. And anyway, I can go on about that in more detail, but the substance use disorders have actually contributed significantly to rising suicides. And just the data are just now, we really weren't even couldn't follow much of the data during COVID, but now some of the data are really coming out showing that, not surprisingly, in 2020, we're up at record highs again. We saw some declines over the last couple of years, and now again, it's up. So yes, I think a long-winded way of saying there's absolutely, I think, an urgent and critical need to address mental health in this country and to put it back onto a value-based model of care where we're actually able to think about a patient holistically, their physical health and their mental health. And there are some initial steps to doing that more, say, within Medicare and within Medicaid. And we also need that, of course, more in the private sector as well. Digital health solutions, I think, have a really significant role to play there, because unlike some of these other diseases where you might need a lot of extra measurements and blood tests and so on, a lot of the services that can be provided for mental health can be done digitally and remotely through apps and phones. And so we've seen a massive uptake there in the last year. What we need to see, I think, is that to be expanded even further, and also to have more data and evidence as to what actually works and what doesn't. And I think that's I'm sure forthcoming pretty soon. But I think that'll be a very important lever for us to be able to accelerate, because we don't have that many psychiatrists, for example. So we need more multiplying effects, and that the digital technology can help there.
Thank you so much, Vivian. We're almost out of time. I'm just going to give you one final question, and then maybe you can provide some concluding remarks. I want to be respectful of your time and our audience members. But one last question. I'm sorry for everyone who put in great questions and I didn't get to all of them. But based on your research, do you believe that employers have the leverage needed to be able to drive change in our healthcare system, even though they are dependent on networks' negotiated rates? What do you think needs to change in order for employers to really be able to drive a difference? And you touched on it a little bit with your example of the I forget the name of the health system, but anyway, and then
Virginia Mason. Yeah. So just since we're out of time, I'll say employers pay for half of the health of all Americans. So in terms of purchasing power, they just need to join forces. And there are some of these groups that have been already formed, but really it's at a local level that they need to do that. That any health system in any community will pay close attention if the employers in that community band together and start setting some expectations. whether it's directly or via their brokers or TPAs. There's enormous, the challenge is that most of those employers aren't experts in this area. And so part of the recommendation, one of the recommendations, for example, that I have is that they really need to get that expertise, whether it's through a consultant or somebody that they have in-house. But they absolutely have the negotiating power to drive that change. And there are multiple examples of that. So that's a great question. So thank you.
Wonderful. Well, thanks so much. And
Yeah.
any last thoughts you'd like to share in the last 30 or so seconds?
No, I'm just honored to be here, and I'm sorry not to be able to see the questions because I can't actually see them. But if you'd like to reach out, of course I have a website, vivianlemd.org, and then I have an email, thelongfix@gmail.com. So feel free to email the questions because I'd love questions and feedback and that exchange. I'd look forward to that.
Wonderful. Well, thank you everyone for joining us today. It's so nice to connect with you, albeit virtually. And Dr. Lee, for sharing your insights on the healthcare system. It's wonderful to connect and hope to see you again soon. Hope to see everyone in a few weeks at our economic summit. We've got a lot of, and you'll be hearing, I'll be hearing more about that soon. So thanks everyone. Have a great rest of your day.
Thank you.